Hello, my name is Paul Mendoza, and I'll be doing a presentation on atypical antipsychotics. Before moving on to talk about atypical antipsychotics, I would first like to talk about schizophrenia, a brain disorder where psychosis is normally seen, and the primary treatment is atypical antipsychotics. So, as far as this pathophysiology, patients who have schizophrenia have significant anatomic abnormalities in the brain compared to those without schizophrenia. One of the abnormalities and differences found in patients with schizophrenia is that their ventricles in the brain appears to be larger than those without schizophrenia. There is a decreased brain volume in the medial temporal area, and lastly, there appears to be changes in the prefrontal lobe, which leads to some of the symptoms of schizophrenia. There appears to be abnormalities as well in the neurotransmitter system. There is an over-secretion of dopamine, and there is involvement of other neurotransmitters such as serotonin. And patients with schizophrenia have a disturbed immune system, which makes them more likely to have an infection. As far as risks and etiology, genetics plays a huge part. Any family history, or if you have a family member who has schizophrenia, it increases your risks of getting schizophrenia. Additionally, any abnormalities during pregnancy that a woman experiences increases the risk of their child being diagnosed with schizophrenia later on in life. Drug use can also lead to schizophrenia. Short-term drug use can lead to substance-induced psychosis, which is managed with short-term use of atypical antipsychotics. But for long-term drug use, you can see patients who have done damage to their brain because of the use of these drugs, and which then leads to a diagnosis of schizophrenia. And lastly, certain infections with certain viruses can lead to a diagnosis of schizophrenia later in life, such as HIV and meningitis. As far as the symptoms of schizophrenia, some of the positive symptoms include psychosis, hallucinations. It could be auditory, visual, or tactile hallucinations, delusions of grandeur, paranoid delusions, and aggressive behavior can also be seen in patients with schizophrenia. Some negative symptoms include decrease in their emotional range, some poverty of speech, and loss of interest in daily activities or in activities that they used to love to do. There are also neurocognitive deficits for patients who have schizophrenia, and then they also have some mood symptoms. So they often have very labile mood, and more often than not, they will probably have a depressed mood. So let's just move on to antipsychotic drugs. So what do antipsychotic drugs do? So the main thing that antipsychotic drugs do is they block dopamine receptors. A lot of them block the D2 receptor. And as mentioned by Karch, it is used to treat disorders that involve the thought processes. They're also called neuroleptic agents. They're called neuroleptic agents because of the known neurological adverse effects that patients experience when they use antipsychotic drugs. So as far as antipsychotic drugs go, there are two different classifications, which is typical, the first generation, and atypical, which is the second generation. This slide shows some of the differences between typical and atypical antipsychotics. So typical antipsychotics are known to have severe adverse effects. On the other hand, atypical antipsychotics, their adverse effects are less severe. They have the same adverse effects, but it is less severe and it happens less often. For typical antipsychotics, extrapyramidal symptoms are expected, and for patients who are taking these medications with Haldol, anti-EPS medication such as cogentin is prescribed in order to combat the EPS, while atypical antipsychotics, EPS is less likely to be seen. Typical antipsychotics are generally harder to discontinue, while atypical antipsychotics are less addicting, therefore it is easier to discontinue. One advantage that a typical antipsychotic has is that it stays longer in the system, so it's easier to get at therapeutic level. atypical antipsychotics is excreted faster in the urine, therefore leading to a greater chance of psychosis relapse. Typical antipsychotics normally mainly just blocks the dopamine receptors, while with atypical antipsychotics, they block both dopamine and serotonin receptors, and sometimes some of them even affect other neurotransmitters. So atypical antipsychotic drugs they're the treatment of choice for schizophrenia, psychotic disorders. They can also be used for patients who are having acute behavioral problems in the form of either PO medication or an IM. Some off-label use that atypical antipsychotic drugs have been used for. Some examples are depression, anxiety, PTSD, and eating disorders such as anorexia. Some caution needs to be done when using atypical antipsychotics for the off-label use, just because of their known adverse effects. Some examples of atypical antipsychotic drugs. Number one is clozapine or Clozaril, which is the first atypical antipsychotic used in the United States, and it is the one that we'll be using as a prototype. Abilify. Interesting fact about Abilify is that there is a long-acting intramuscular injection available in the form of Abilify Maintena, which patients can use once every 4 weeks to maintain the Abilify in their body. Latuda, Zyprexa. Another interesting fact about Zyprexa is that it is available in different forms. So there is Zyprexa PO, which patients can take as a tablet. It is also available sublingual, and it can also be used as an intramuscular injection for patients who are experiencing acute aggressive or acute anxiety. Seroquel. Seroquel, in addition to being an antipsychotic, I've seen it used to help patients with their anxiety, and also I've seen it used for patients who have been having trouble with sleep. So for patients with insomnia, Seroquel is used to help them go to sleep. And lastly is Risperidol. So a mechanism of action of atypical antipsychotics, it blocks the D1 to D5 receptors. Most of them block the D2. So as I was talking about earlier with schizophrenia, is that there's an increased production of dopamine, which leads to an increased impulses in the brain. So by blocking these dopamine receptors, it leads to a reduction of stimuli, which leads to better thought processes, reduction of psychosis, and reduction of the psychotic symptoms. There also appears to be a blockage of serotonin receptors. The blockage of serotonin receptors leads to reduced neurologic effects or reduced of the EPS compared to those of the typical antipsychotics. And also, since it blocks serotonin receptors, there appears to be a reduced amount of depression or depressed mood in patients taking atypical antipsychotics compared to those with typical antipsychotics. Clozaril. As I said earlier, it is the first atypical antipsychotic used in the United States. For the initiation of use, the initial dose normally starts at 25 milligrams per day, increasing daily. A safe therapeutic goal range for patients using Clozaril is around 300 to a maximum of 900 milligrams a day. It is not recommended to go above 900. For older adults, it is recommended to start them at 100 milligrams and slowly move them up to 150 and monitor for effectiveness, and then slowly move them up to 300 as needed. For patients who are to be started on Clozaril, they need to be registered in the Clozaril registry. It is a national registry that monitors patients who are on Clozaril, and the doctor needs to be certified to prescribe Clozaril. The main reason is a serious adverse effect of Clozaril is agranulocytosis, which lowers a patient's white blood cells and neutrophil count, which increases their risks for infection. A common side effect of Clozaril is sedation, which is something that we need to watch out for. And because of the risk for agranulocytosis, weekly CBC is recommended for patients who are taking Clozaril, and most importantly, at the beginning of the initiation of Clozaril, a baseline CBC needs to be taken. Some of the therapeutic goals for patients taking Clozaril, it's for the management of psychotic symptoms for patients with schizophrenia, reduction of suicidal behavior, reduction of acute behavioral problems such as aggression or agitation. Like I said earlier, Zyprexa IM is normally the atypical antipsychotic used for patients who are aggressive and agitated. And of course, we need to keep the lab values being monitored weekly. Of course, these values depend on the facility or the hospital where you're working for. As far as my facility, these are the sample numbers. We follow 3.5 to 10.5 for white blood cells and 2 to 8 for the absolute neutrophil count. Some of the known adverse effects of Clozaril use involves in atypical antipsychotic use. Adverse effects of Clozaril and atypical antipsychotic use. The most dangerous one is neuroleptic malignant syndrome. It is a medical emergency and it is lethal. This neuroleptic malignant syndrome. It's hard to detect because it could appear as just an increase in the manifestation of a psychosis of the patient. But really, what needs to be monitored is a patient's vital signs. It is a main indicator because some of the symptoms of patients with neuroleptic malignant syndrome is there appears to be fever, their temperature spikes up, there is some rigidity, myoclonus, their heart rate raises, there is hypertension, their blood pressure shoots up, there's autonomic instability, and diaphoresis. It is very important. The main thing about neuroleptic malignant syndrome or NMS is early detection. Early detection of NMS is the most important in terms of patient survival. Next, we're talking about the next adverse effect is metabolic syndrome. So metabolic syndrome is the name for a group of risk factors that raises a patient's risk for heart disease and other health problems such as diabetes and stroke. So patients who use atypical antipsychotics normally have an increase in metabolic syndrome. So they have weight gain, they have an increase in blood sugar, which leads to obesity. Another adverse effect of Clozaril or atypical antipsychotic use is there is an increased risk for seizure. Also, for patients using Clozaril, there could be some drowsiness, weakness, and sedation, and also nausea and vomiting. Some contraindications for patients using atypical antipsychotics. So elderly patients with dementia, I've seen it sometimes when I used to work in a skilled nursing facility where a patient with dementia would appear to have some psychotic symptoms, and so an atypical antipsychotic would be prescribed to manage those psychotic symptoms. It is not recommended to use this just to manage those psychotic symptoms because use of atypical antipsychotics increases the risk for cardiovascular episodes and stroke. Like I said earlier, there's an increased risk for seizure for patients who use atypical antipsychotics. So patients who already have seizure disorder, they need to be monitored while they're using atypical antipsychotics. Atypical antipsychotics are also known to affect a patient's immune system. With the metabolic syndrome, there appears to be an increased risk for being diagnosed with diabetes mellitus type 2, or even if a patient is already diagnosed with diabetes mellitus type 2, it would be harder to manage the diabetes. There's also caution should be taken for patients who are taking multiple atypical antipsychotics altogether because there could be an increased risk for the adverse effects that we talked about earlier. Some food and drug interactions. So for food interactions, of course, number one, avoid alcohol because of the increased sedative effects. There appears to be a minor interaction with caffeine and atypical antipsychotic use, but that is very, very minor. Proper diet is recommended for patients taking atypical antipsychotics. mainly because of the metabolic syndrome. We want to be able to help the patients manage their weight and their blood sugar. Some drug interactions, like I said earlier, caution needs to be taken when multiple antipsychotic medications are being taken together because of the increased risk for more adverse effects happening. Caution should be taken as well when patients are taking benzodiazepines or other anti-anxiety medications, such as antihistamines, such as Vistaril, because of the increased sedative effects. Autoimmune suppressants, patients should be very cautious when they're using autoimmune suppressants such as corticosteroids while taking atypical antipsychotics. And the use of live vaccines should not be done when for patients who are on atypical antipsychotics. Some cultural considerations. There appears to be some symptomatic variance in patients from different cultures. By that, I mean there's a difference in rates in occurrence of hallucinations. So some cultures report more auditory hallucinations, for example, as compared to other cultures, and some report more visual hallucinations compared to other cultures as well. There also seems to be a difference in hallucinations perceived. For example, in one of the studies that I went over in one of the articles, it appears that Western cultures appears to see things more concrete, so they see like figures, people, forms, the voices that I hear are people that they know, while as Eastern cultures they see more abstract things, so they see more like lights, moving backgrounds, and things like that. There seems to be a diagnostic variance in between cultures. Psychiatrists can be influenced by their own bias, and their own culture and race could affect the way that they diagnose as another patient. There also appears to be a racial and diagnostic stigma. One of the studies that I was reading is in the mid-90s, there appeared to be a higher diagnosis rates for African Americans to be diagnosed with schizophrenia as compared to their Caucasian American counterparts. There also appears to be treatment variance in terms of consent and voluntary versus involuntary medication administration. So in Western cultures, it is more frowned upon, or it is seen as illegal for patients to be forced to take medications such as an intramuscular medication injection when the patient is having an acute aggressive behavior. On the other hand, let's say with an Eastern culture where it's a more family decision based, forcing a medication on a patient when it's the family decided it appears to be more acceptable for them. Some nursing considerations for patients when taking care of patients who are taking Clozaril. Of course, CBC lab values need to be monitored weekly. White blood cell and absolute neutrophil counts need to be checked because of the risk of agranulocytosis, which increases the risk for patient's infection. Vital signs. It is very important to monitor patient's vital signs just in case there is onset, for the early detection of the onset of infection or NMS. Certain atypical antipsychotics may need to be given at bedtime due to the effects of sedation and weakness. So some of these atypical antipsychotics are Seroquel and Clozaril are normally given at night because of the sedative effects. And of course, proper diet, adequate fluid intake, and some lifestyle changes need to be done in order to manage the metabolic syndrome. The first article that I chose to review is entitled Atypical Antipsychotics and Metabolic Syndrome in Patients with Schizophrenia. It is an article by Reardon, Antonini, and Murphy, written in 2011. As I said earlier, metabolic syndrome is the name for a group of risk factors that raises your risk for heart disease and other health problems such as diabetes and stroke. According to the authors, metabolic syndrome is the leading cause of morbidity and mortality in patients with schizophrenia. And the treatment of schizophrenia involves a delicate balance in terms of risks and benefits because failing to treat as a result of risk for or complications from metabolic syndrome may place the patient at a higher risk for more serious problems or even suicide. Atypical antipsychotics, as I said earlier, is widely used off-label, and so monitoring the patients for their use of these medications is important, especially the incidence of metabolic syndrome. Weight gain is a well-known side effect of atypical antipsychotic medication. There are racial and ethnic differences in the manifestations of metabolic syndrome. For example, some cultures are more likely to manifest heart disease, while others tend to manifest diabetes mellitus. Different atypical antipsychotics carry higher risks for metabolic syndrome. In a study by clinical antipsychotic trials in intervention and effectiveness, they tested 600 patients in a span of 3 months who are using atypical antipsychotics. They saw that olanzapine had the greatest prevalence of metabolic syndrome. As we know, schizophrenia is a chronic and costly illness, not only for the patients, but also for the family that are taking care of the patient. So it's not only financially costly, but it's also very stressful emotionally as well. There is difference. Why is there a difference in the different atypical antipsychotics? Because, as I said earlier, other than being dopamine receptor antagonists, certain different atypical antipsychotics also block other neurotransmitters. For example, olanzapine and clozaril have more effect on body weight because they have been found to also have a high affinity for histamine or H1 receptors. Of course, risk for metabolic syndrome increases in the elderly, and the authors recommend that assessments be done at baseline, 4 weeks, 8 weeks, quarterly, annually, and every 5 years to assess their modifiable and non-modifiable risk factors. Some of the assessments include monitoring lab values, monitoring waistline weight, and all that other assessment details that need to be monitored. The second article that I chose to review is entitled Neurologic Malignant Syndrome During Multiple Antipsychotic Therapy. It is an article by McDermott, Lucy, and Fromm. I chose this article because it is a case study that follows the case of Mr. A, who is a 50-year-old male who was previously living in a skilled nursing facility who presented to the ER due to having a multiple psych diagnosis and multiple psych medications, and appeared to be with depressed affect and agitation, but didn't have any evidence of psychosis. He had been previously prescribed with multiple antipsychotic medication, and 3 weeks prior to this admission to the hospital, he was prescribed with 600 milligrams of quetiapine or Seroquel, and he had also been prescribed with PRN, Seroquel, with increasing dosages due to his increased agitation. In the day 4 of his hospitalizations, his medications were adjusted. So he was previously prescribed with Zyprexa. That was taken out and was replaced with a different medication. 2 days after that change, he appeared to have some Parkinsonian symptoms and had some stiffness and had contracted gait. In day 6, they found that he was confused, drooling, his arms were drawn to the body, he was feverish at 39 degrees Celsius, and he is hypertensive. He had increased blood pressure of 193/91, and he was found to be diaphoretic. His O2 saturation was 91% on room air. Neurologic malignant syndrome was suspected. Cogentin 2 milligrams was given intramuscularly immediately, and antipsychotic medications was withdrawn, and oxygen was immediately started. Immediate results were seen. He became less stiff, and his blood pressure had decreased immediately. During his hospital stay, he was managed using PRN, lorazepam, and clonidine to manage his blood pressure, and was given cooling measures such as cooling pad in order to maintain his temperature and to lower the fever. As we see in Mr. A's case, antipsychotic polypharmacy increases the risk for NMS, and the rapid increase of quetiapine and the high dose of prescription increased his risk of contracting NMS. And as we see in this case, the early detection and early treatment of NMS led to a good outcome for Mr. A. Here I'm showing you the brochure that I made for this presentation, and I entitled it "What Are Antipsychotics?" And I'm using clozapine as my prototype medication. It shows its primary function was to block dopamine and serotonin receptors. It is used for reduction of psychotic symptoms and the management of acute aggressive behavior episodes. It helps in the treatment of schizophrenia, schizoaffective disorder, and other psychotic disorders. It shows off-label use, and it shows that the caution should be had when using atypical antipsychotics or clozaril for off-label use. I put in some information about schizophrenia, some causes, symptoms, some warnings when using clozaril, atypical antipsychotics, so the clozaril's adverse effects, things to consider, so the food interactions, drug interactions, when to see a doctor. So definitely when you're experiencing an MS, so high fever, rigidity, tachycardia, extreme diaphoresis, and always make sure to have your lab values monitored weekly. So white blood cells and absolute neutrophil counts is definitely a must need to be monitored weekly. Thank you.